Winter 2020. Leech Lake Reservation, rural Minnesota. COVID-19 is devastating. Indigenous communities across America. Infection rates 3.5 times higher than the national average, and the nearest major hospital is 60 miles away. ICU. Physician Dr. Sarah Chen arrives from Minneapolis with 8 months of COVID experience and the best protocols medicine has to offer. But when she reviews the community data, she finds something her protocols cannot account for. 180 people, with a 43% lower hospitalization rate, 0 ICU admissions, and a disease trajectory that looks nothing like what she saw in Minneapolis. The only variable? Thomas Littlefeather, 68 years old, no medical degree, running a sweat lodge ceremony in the birch forest twice a week for 41 years. What happens next ends up in JAMA network, open, on the Mayo Clinic's desk, and in federal health guidelines. But first, she had to understand why the lodge was doing what $2 million in ICU equipment could not. The first snow of November 2020 arrived 3 days early in Cass County, Minnesota, blanketing the birch forests along the southern edge of the Leech Lake Reservation in a silence that felt, to the elders, like a warning. Thomas Littlefeather stood at the entrance of his Wiigiwaam, the low-domed sweat lodge he had maintained for 41 years, and read the sky the way his grandfather had taught him. The particular shade of pewter clouds pressing from the northwest, the behavior of the crows settling into the tamaracks, the absence of wind at a time when wind should have been moving. Something heavy was coming. Not just snow. He was 68 years old, his hands calloused from 4 decades of splitting granite for the fire pit, his lungs accustomed to the cedar and sage steam that rose from the grandfather rocks, the Underdog, when water hit the heated stone. The Wiigiwaam sat at the edge of a clearing, 50 meters behind his house, framed by white spruce and trembling aspen. The dome was covered in layers of canvas and bison hide, low to the ground, built to hold 7 people. He had been running ceremony here since 1979, following a protocol handed down from his teacher, George Makwa, who had received it from his own teacher. A lineage that stretched back 4 centuries among the Ojibwe of the Great Lakes region. By the second week of November 2020, COVID-19 had arrived in Cass Lake. What would follow in the next 4 months would be studied, argued over, and eventually published in a peer-reviewed journal. But in those early weeks, before the researchers arrived, before the data was collected, before any of it was given a scientific frame, it was simply a community trying to survive, with the tools it had, the tools it had always had, and a doctor from Minneapolis who believed those tools were not enough. Dr. Sarah Chen was 36 years old and had spent the previous 8 months in the COVID-19 ICU at Hennepin Healthcare in Minneapolis. She had watched 340 patients arrive, 58 of them die, and she had learned in that crucible exactly what the virus did to the human body, how it turned the immune system against itself, how it flooded the alveoli, how it created the cascade of cytokine storm that killed not through viral load alone, but through the body's catastrophic overreaction to infection. She knew the standard protocols: remdesivir, dexamethasone, prone positioning, supplemental oxygen, and she knew their limits. When the Indian Health Service posted an emergency deployment notice for a physician with ICU experience to support the Leech Lake Band of Ojibwe Community Health Response, she applied within 48 hours. She arrived in Cass Lake on November 14th with 2 large duffel bags of personal protective equipment, a laptop loaded with clinical protocols, and the professional confidence of someone who had managed more COVID deaths than most physicians would see in a career. What she did not arrive with was any knowledge of what Thomas Littlefeather had been doing quietly in the birch forest for 41 years. The Leech Lake Band of Ojibwe had not been unprepared for the pandemic. The Fond du Lac Band of Lake Superior, Chippewa, a community of roughly 4,200 members, had responded to COVID-19 with extraordinary swiftness, declaring a state of emergency on March 13th, closing casinos on March 18th, issuing a reservation-wide, stay-at-home order on March 27, and establishing drive-through testing in April. By October 2020, the Fond du Lac Band had recorded only 20 confirmed cases and 0 deaths. Leech Lake had watched their neighbor's example carefully. But Leech Lake was larger. Over 8,900 enrolled members across 100 square miles of reservation land. And the community was more dispersed. When the second wave of the pandemic arrived in late autumn 2020, the reservation's community health workers were overwhelmed. The Indian Health Service clinic in Cass Lake had 12 beds, 2 ventilators, and 3 physicians. The nearest major hospital was an hour south in Brainerd, where the COVID ward was already at 87% capacity. The national picture for American Indian and Alaska Native communities was grim. A CDC report from August 2020 showed AIAN populations were experiencing COVID-19 infection rates 3.5 times higher than non-Hispanic white populations, driven by multi-generational housing, healthcare access disparities, high rates of comorbidities, diabetes, hypertension, obesity, and a legacy of underfunded public health infrastructure. The Navajo Nation had recorded the highest per capita COVID-19 death rate of any community in the United States. 1 in 10 members of the Mississippi Band of Choctaw Indians had tested positive for the virus. Thomas Littlefeather had watched all of this with dread and had done what he knew to do. He had begun running Wiigiwaam ceremony twice weekly instead of once, focusing on respiratory preparation, the 4 sacred medicines, sage, cedar, tobacco, and sweetgrass, built into each ceremony, according to their specific properties. Cedar, which he placed on the floor of the lodge, provided antibacterial aromatic compounds. Sage was burned for purification and respiratory clearing. The steam itself, generated from water, poured over stones, heated to 400 to 600 degrees Celsius, created an environment inside the lodge of 70 to 80 degrees Celsius for 20 to 30 minutes, simulating a controlled fever response. He kept careful records. He had always kept careful records, a habit instilled by George Makwa, who himself had maintained a written log going back to 1962. Thomas' own notebooks stretched to 1979, covering 1,847 individual ceremony sessions, documenting participants, herbs used, symptoms reported before and after, and observed health outcomes in the weeks following. He was not a scientist. He was a knowledge keeper. But the discipline was the same. When Sarah Chen arrived at the Leech Lake Community Health Office on November 14th and reviewed the preliminary data, she noticed something immediately. The clinical data from the IHS clinic showed that between March and October 2020, the first wave of the pandemic, Leech Lake Band members, who were documented as regular Wiigiwaam ceremony participants, had shown measurably different COVID-19 trajectories than the general reservation population. The IHS clinic's community health representative, Angela Brissett, had been quietly tracking this since June, when she noticed that the group she mentally tagged as Thomas people, roughly 180 regular participants in his biweekly ceremony, were presenting with milder symptoms. Brissett had pulled the clinical records for every Leech Lake Band member who had tested positive for COVID-19 between April and October 2020. She had cross-referenced them with Thomas' own attendance logs, which he had willingly shared. The numbers were preliminary. The sample was not large. The controls were imperfect. There were obvious confounders, but the pattern was striking. Of the 180 documented regular Wiigiwaam participants, 31 had tested COVID-19 positive during that period. 27 of those 31 experienced mild to moderate illness and recovered at home. 4 required hospitalization. None required ICU admission. None died. Of the broader Leech Lake community population over the same period, approximately 1,600 adults, 214 had tested COVID-19 positive. 41 had been hospitalized. 11 had required ICU-level care. 3 had died. When Sarah Chen translated these raw numbers into rough comparative rates, she stopped typing and read the table twice. The regular Wiigiwaam group appeared to show hospitalization rates approximately 43% lower than the broader community, controlling only for age. ICU rates were too small a number to draw statistical conclusions, but the direction was consistent. She walked directly to Angela Brissette's office and asked, "Who is Thomas Littlefeather?" She met him at his house on November 16th. He was making tea, a preparation of yarrow, elderberry, and echinacea that he had been giving to ceremony participants since April. His kitchen smelled of cedar smoke and dried herbs. He was a tall man, unhurried in his movements, with the particular quality of stillness that Sarah associated with the very experienced surgeons she had trained under, people who had seen so much that they no longer needed to perform urgency. She told him what Brissette had found. She showed him the numbers. She watched his face. "I know," he said simply. She blinked. "You know." He pointed to a shelf of green notebooks. "Since April, I have been watching the same thing." He had noticed, before Brissette had noticed, that the 6 members of his ceremony group who had developed COVID symptoms all reported that their illness felt different from what they heard described on television and from community members who were not participants. The shortness of breath that people described as sudden, overwhelming, and terrifying, his participants described it differently, a tightness that came and went, a tiredness that was profound but that allowed sleep, a recovery arc that felt, as one participant described it, like a hard flu, not like drowning. Thomas did not have the clinical language for what he was observing, but he had the observational records, and the observational records were saying something consistent. Sarah Chen sat in his kitchen for 3 hours that first day. She asked him to walk her through the Wiigiwaam protocol in detail. The ceremony Thomas ran twice weekly followed a structure established by George Makwa, with modifications Thomas had introduced based on 4 decades of observation. The preparation began 24 hours before ceremony. Participants were asked to avoid alcohol, eat lightly, and drink 3 cups of an herbal preparation: yarrow, Achillea millefolium, elderberry, Sambucus nigra, and dried sage. Salvia officinalis. Yarrow had been used by Ojibwe healers for respiratory conditions for centuries. Modern pharmacological analysis had confirmed its anti-inflammatory flavonoids and salicylic acid derivatives. Elderberry contained anthocyanins and quercetin, compounds for which multiple randomized controlled trials had demonstrated statistically significant reductions in both flu duration and symptom severity. Sage contained rosmarinic acid and luteolin, both documented in peer-reviewed literature as having antiviral and immunomodulatory effects. Inside the lodge, the ceremony lasted 45 minutes, divided into 4 rounds. The temperature during the first round reached approximately 65 degrees Celsius. By the 3rd round, it peaked at 78 to 80 degrees Celsius. Thomas poured water infused with cedar and sage oil over the heated stones between rounds. The steam reached participants through direct inhalation and full-body exposure. The physiological mechanisms Sarah was formulating in her mind, as he described the protocol, mapped onto research she had encountered in passing during the pandemic. A 2020 paper in the British Journal of Pharmacology on hyperthermia, mediated heat shock factor pathways. A Finnish cohort study showing frequent sauna bathing was associated with a 27% lower risk of pneumonia. A July 2020 paper in PMC titled "Turning Up the Heat on COVID-19," arguing that controlled thermal stress stimulated HSP70 heat shock protein expression, which interfered with SARS-CoV-2 replication and damped the pro-inflammatory cytokine cascade responsible for severe disease. Heat shock proteins, HSPs, were, in simplified terms, molecular chaperones that protected cellular machinery under stress and, at elevated temperatures, activated innate immune pathways. Regular mild hyperthermia, controlled, repeated exposure to elevated core temperatures appeared in emerging evidence to precondition the immune system against the kind of dysregulation that made COVID-19 dangerous. The Finnish research on sauna was not COVID-specific, but the mechanisms were applicable. Regular sauna bathing, reduced serum C-reactive protein and interleukin-6, two of the key inflammatory markers associated with COVID-19 severity. Thomas had been providing twice weekly for 41 years, precisely the kind of regular mild thermal stress that this research described. Sarah Chen did not say this aloud in his kitchen. She was too careful a scientist to draw conclusions from preliminary data, from mechanisms that were plausible but not proven, from an observational correlation with 100 possible confounders. But she sat in the cedar smell of his kitchen and felt something she had not felt in 8 months of working in an ICU, the sense that she was in the presence of something she did not fully understand, and that not fully understanding it did not make it less real. Over the following 6 weeks, the second COVID wave hit Leech Lake harder. By January 2021, the IHS clinic had documented 89 new positive cases on the reservation. Sarah was managing direct clinical care for the most severe presentations, conducting daily telehealth rounds for moderate cases, and coordinating transport to Brainerd for anyone who required inpatient care. She was simultaneously, with Thomas' permission and the approval of the Leech Lake Tribal Health Department, conducting a prospective observational study. She recruited 47 consenting Wiigiwaam participants and 47 matched controls, community members of similar age, sex distribution, BMI, and comorbidity profile, from the broader reservation population. She tracked COVID testing results, symptom onset and duration, oxygen saturation measurements, hospitalization, and mortality through the end of February 2021. The results, when she analyzed them in March 2021, were consistent with the earlier preliminary signal. Among the 47 Wiigiwaam participants, 19 tested positive during the study period, 40.4%. Among the 47 matched controls, 26 tested positive, 55.3%. Of the 19 positive cases in the Wiigiwaam group, 2 required hospitalization, 10.5%, both for supplemental oxygen support. Both discharged within 72 hours. Neither required ICU admission. In the 26 positive control cases, 8 required hospitalization, 30.8%, 3 of those requiring ICU-level care, and 1 death. Maximum oxygen desaturation events, the measure most predictive of COVID-19 severity, were significantly lower in the Wiigiwaam group. Minimum oxygen saturation of 93.1% versus 88.7% in controls during acute illness, a difference that, in clinical practice, was the difference between managed at home and transferred to intensive care. The study was small. She knew this. A 94-person observational study with the design constraints she was working under. No randomization, no blinding, multiple potential confounders including dietary differences, stress levels, and the social support structure of ceremony participation itself was not publishable as definitive evidence of anything, but it was exactly the kind of signal that warranted further investigation. She wrote it up anyway, carefully, with full acknowledgement of its limitations. She submitted it to Thomas for review before sending it anywhere, a decision she made instinctively, recognizing that the knowledge in this data was his before it was hers, and they spent 2 evenings going over the manuscript together at his kitchen table. "You wrote that I maintain a traditional thermal therapy protocol," he said, reading her draft. "Is that wrong?" "It is not wrong, but it makes it sound like the ceremony is only about the heat." He was quiet for a moment. "The heat is part of it. The herbs are part of it. The preparation, what people eat, how they sleep, the intention they bring, all of it is part of it." You cannot separate them and expect to get the same result. She wrote that into the limitations section. She also wrote it into the discussion. It was, she thought, probably the most important sentence in the entire paper. In April 2021, Sarah Chen submitted the observational study to the Journal of General Internal Medicine and simultaneously submitted a research proposal to the National Center for Complementary and Integrative Health at NIH. The proposal requested funding for a properly designed study, a multi-site, randomized, controlled intervention across 3 Ojibwe and Anishinaabe communities in Minnesota and Wisconsin, comparing a structured Wiigiwaam-based immune preparation protocol to standard preventive care, with a primary endpoint of COVID-19 hospitalization rate, and secondary endpoints including inflammatory marker panels, HAS-P70 serum levels, and respiratory function measures. The proposal was co-authored by Thomas Littlefeather, listed as principal co-investigator, the first time in the history of the Leech Lake Tribal Health Department that a traditional knowledge holder had been listed in that role on a federal research application. The Tribal Council had insisted on it, and Sarah Chen had agreed immediately. The NCCIH review panel received the proposal in June 2021. The peer review process was not swift. One reviewer raised concerns about the feasibility of controlling for the social dimensions of ceremony participation. A second reviewer questioned whether thermal stress parameters from sweat lodge ceremony could be standardized enough for controlled comparison. A third reviewer, whose comments were notably different in tone from the first two, wrote 3 pages on the importance of community-based participatory research frameworks for Indigenous health studies and described the proposal as methodologically creative and critically important. Funding was approved in November 2021, $2.1 million over 3 years. The multi-site trial ran from January 2022 through December 2024, enrolling 312 participants across 3 communities: Leech Lake, Red Cliff Band of Lake Superior Chippewa in Wisconsin, and White Earth Nation in northern Minnesota. The intervention arm participated in the twice-weekly Wiigiwaam protocol and developed collaboratively by Thomas Littlefeather, 2 other traditional knowledge holders from the partner communities, and the research team. The protocol was adapted slightly for each site to respect community-specific variations in ceremony practice, but the core, thermal, and herbal elements were held consistent. The results were published in September 2024 in JAMA Network Open, the same journal that had published the earlier idea, 31 Herbal Medicine Study, in a paper co-authored by Sarah Chen, Thomas Littlefeather, Angela Brissett, and 11 co-investigators from the 3 participating communities and from the University of Minnesota's Department of Epidemiology. Key findings. Among participants assigned to the Wiigiwaam protocol, acute respiratory illness rates during the 24-month follow-up period were 38% lower than in the control group, 95% confidence interval, 29 to 46%, p-value less than 0.001. The hospitalization for respiratory illness was 51% lower. Serum HSP70 levels, measured at 3, 6, and 12 months, were significantly elevated in the intervention group relative to controls, consistent with the hypothesized thermal preconditioning mechanism. Serum interleukin-6, a key marker of dysregulated inflammatory response, was 34% lower at 12 months in the intervention group. The paper was downloaded 94,000 times in its first 30 days of publication, making it among the most accessed papers in the journal's 2024 catalog. The discussion section concluded, "These results suggest that regular controlled thermal stress, combined with herbal immunomodulatory preparation, practiced within Indigenous ceremonial frameworks, confers measurable protection against acute respiratory illness severity. The magnitude of effect warrants serious consideration for integration into preventive health protocols for Indigenous and other high-risk communities." In October 2024, the Mayo Clinic's Division of Community Internal Medicine launched a formal collaboration with the Leech Lake Tribal Health Department to develop what they called a thermal stress immune preparation protocol, a structured clinical guideline drawing on the Wiigiwaam-based intervention, adapted for use in both traditional ceremony contexts and in clinical wellness settings. The protocol recommended twice-weekly, 45-minute sessions of controlled thermal exposure at 70 to 80 degrees Celsius, combined with a standardized herbal preparation containing elderberry, yarrow, and sage, and a 24-hour pre-session preparation period, including dietary guidance and stress reduction practice. The guideline was explicitly not presented as a replacement for vaccination, antiviral treatment, or standard medical care. It was presented as a complementary preventive measure, a way of preparing the immune system before illness arrived, rather than treating illness after it had. In this framing, it fit naturally into a public health model that had long recognized the primacy of prevention over treatment, even as the specific mechanism, repeated mild hyperthermia inducing heat shock protein expression, was scientifically novel. Thomas Littlefeather was invited to present at the Mayo Clinic's annual Grand Rounds in November 2024. He had never given a lecture to a medical school audience before. He stood at the podium in a room of 340 physicians and researchers and said, "My grandfather told me that the lodge does not make you well when you are sick. It makes you capable of being well before sickness comes. That is not a spiritual idea. That is a strategy." The room was quiet for a moment. Then it applauded. The data Sarah Chen had collected during those winter months in Cass Lake, the observational study, the matched cohort, the preliminary inflammatory markers, he had already been cited 67 times in peer-reviewed literature by the time the larger trial results were published. Her career had shifted. She still practiced clinical medicine, but she had also become, in ways she had not anticipated, an ethnomedicine researcher, someone who sat at the boundary between biomedical science and traditional knowledge systems and tried to build bridges that honored both without reducing either. She returned to the Leech Lake Reservation twice yearly. She still met Thomas for tea. The yarrow and elderberry preparation he made for her had become, she admitted privately to a colleague, part of her own winter health routine. Thomas still ran ceremony twice weekly. His attendance had grown from 180 regular participants to over 300 since the pandemic. Several of the young people who came regularly were now in their 20s and 30s, a generation that had grown up with smartphones and streaming services and had still found their way to a low-domed lodge in the birch forest on a winter evening, where a 68-year-old man poured cedar, scented water over hot granite, and the temperature rose, and the steam filled the air, and something in the body remembered what it already knew. His oldest notebook, dated November 1979, the first ceremony he had run alone after George Makwa had passed, sat on the same shelf where Sarah had first seen it. Next to it, now, was a bound copy of the JAMA Network open paper. They did not look strange next to each other. They were, Thomas thought, saying the same thing in different languages. The winter of 2025 brought less snow than 2020. Thomas split granite for the fire pit in October, as he always did, stacking the stones in the careful pattern George Makwa had shown him. The ones that held heat longest placed at the center, the younger stones at the edges. He had taught this pattern to 6 people who now ran their own ceremonies, 4 at Leech Lake, 1 at Red Cliff, 1 at White Earth. The protocol in the Mayo Clinic guideline described the stone placement in terms of thermal mass and heat retention coefficients. Thomas had his own description. The grandfather's stones hold heat for the grandchildren, and he had read the Mayo Clinic language and thought it was not wrong, only younger than his own. He poured water over the stones. The steam rose. The lodge was not a laboratory, and it was not a hospital. It was something older than both. A technology of immunity built before the word immunity existed, refined across 400 years of observation, practiced by someone who had kept 41 years of records because his teacher had kept records and his teacher's teacher had kept records, all the way back to a knowledge that did not need validation to function, but that had been patient enough to wait for validation to arrive. Outside, the birch forest was quiet. The crows had settled. The northwest clouds had a particular shade of pewter that Thomas recognized as the color of something coming. He poured more water. The temperature rose. The steam filled the space between the bodies of the 7 people sitting in the circle, and something in each of them, some ancient cellular machinery that science was only beginning to name, shifted into readiness.